Hi everybody, this is Molly and I'm going to be presenting on alcoholism and addiction. First, I'd like to start with a little bit of background information. Dependency on alcohol, also known as alcohol addiction or alcoholism, is a chronic disease. The signs and symptoms of alcohol dependence include a strong craving for alcohol, continued use despite repeated physical, psychological, or interpersonal problems, and the inability to limit drinking. Previously, the DSM-4 had described, sort of two distinct disorders, alcohol abuse and alcohol dependence, with specific criteria for each. But currently, the DSM-5 integrates these two disorders into a single disorder, now called alcohol use disorder, or AUD, and this has mild, moderate, and severe sort of subclassifications. This slide contrasts the previous DSM-4 criteria with the newly published DSM-5 criteria for alcohol use disorder. And essentially, a patient would be asked to answer the questions in blue under the context, in the past year have you? And then you can see on the side there how they delineate between the mild, moderate, and severe subclassifications. I think this is a pretty simple, cost-effective, time-effective screening tool that clinicians could use in practice. For some epidemiology, the scope of this illness in the United States, as you can see, is pretty impressive. Close to 90% of people in the United States reported drinking alcohol at some point in their lifetime, and of these, over half reported drinking alcohol in the last month. On the alcohol use disorders side of the slide, you can see that 16.6 million adults and close to 1 million adolescents, which was surprising to me, suffer from alcohol use disorders. And alcohol currently accounts for about 88,000 deaths annually, which makes it the third leading preventable cause of death here in the country. And in terms of an economic burden, alcohol misuse problems are thought to cost the United States over $223.5 billion per year. So quite the economic burden. The physiology of alcoholism and other substance abuse disorders are fairly complicated, but mostly because it's so multifactorial. But in short, alcohol affects several of the neurotransmitter systems in our brain, mainly dopamine, GABA, glutamine, and serotonin. It acts through the mesolimbic pathway through various receptor systems to initiate an immediate reward, and over time, it reinforces this reward through repeated alcohol use. The psychobiologic theory of addiction has really helped me to understand and even to, believe in this disease model of addiction. According to the psychobiologic theory, alcohol and substance dependence results from a combination of genetic and environmental factors. This theory provides a biologic basis for substance abuse and dependence, and explains why individuals who are genetically predisposed to addiction and are then exposed to environmental triggers become addicted ultimately to alcohol or drugs. For example, because alcoholism runs in my patient's family and he grew up in a fairly chaotic home environment, the psychobiologic theory of addiction would predict him to be at a higher risk for growing up to become dependent on alcohol and drugs. If anyone's interested in learning more about the psychobiologic theory of addiction, I would highly recommend, researching it a little bit more. I think it's a really helpful theory to understand better if a friend or relative is suffering through addiction. I find this theory an especially helpful explanation of addiction and substance abuse. A recent study by Carrican discovered a unique link between alcoholism and a specific nucleotide polymorphism on a single GABA receptor gene. By identifying such, specific genetic components, clinicians are able to identify certain individuals as being at increased risk for developing alcohol or drug addiction. And I think that by identifying these high-risk individuals earlier on, we'll ultimately be able to plan more timely interventions and hopefully end up with better patient outcomes. Okay, so my patient, T.E., I first met him when I was a volunteer down in Denver at Cedar, which is this really intensive inpatient addiction treatment facility associated with the University of Colorado Hospital. And our paths crossed again recently since he relocated up here in the mountains. I actually just ran into him on the ski mountain, and I was trying to think of a patient for this project, so I asked him if he'd be willing to participate in this sort of 6-week project geared towards improving his alcoholism self-management, and he gladly agreed. So at our first meeting, TE and I worked on some goal setting for the course of the project. I asked him to identify 3 goals where he would like to focus on. He said that in addition to staying sober, the sort of obvious goal, that he would like to find an AA meeting where he felt comfortable attending. He'd like to participate in some healthy activities that would allow him to make friends outside the AA community, and he'd like to choose a new primary care provider and ideally find a new local counselor. Using Gordon's functional health assessment template, I completed a health assessment with my patient. As you can see, he's a 31-year-old Caucasian male, and aside from his alcohol addiction, TE does not smoke tobacco or use other illicit drugs. He describes himself as generally healthy. He has never been hospitalized. He hasn't been to the doctor recently for any cold symptoms or anything like that. He eats a fairly balanced diet. He says 3 to 5 meals a day, lean proteins, vegetables, fruits, that kind of thing. And he really enjoys exercise. He goes to the gym almost every day, and he tells me he gets about 30 to 45 minutes of vigorous exercise a week or a day. He has no sleeping problems, no apparent cognitive deficits, but unfortunately he has a fairly poor self-concept, all related to his alcoholism, and he is lacking family and close social relationships. TE is sexually active, and he struggles with coping skills because previously his coping skills all, sort of revolved around drinking. So going forward, that's an area he'd like to improve. And he describes himself as spiritual, though not particularly religious. In terms of his disease trajectory, TE had his first drink at age 12, and that was right around, he says, the time his parents got divorced. He grew up in a fairly chaotic home environment with his mom and dad fighting a fair amount. And then his dad passed away when he was around 19 years old. His father was 57, I believe, when he died. And the cause of death was esophageal cancer related to a long history of tobacco and alcohol abuse. And TE says this is when he sort of spiraled out of control with his drinking. In the past 5 years, he's spent 5 stays in intense inpatient rehab facilities for his alcohol addiction. And most recently, upon completing the program, he moved to the Vail Valley in an effort to sort of distance himself from his old life and old triggers. But, of course, with that move came some new challenges. Another area that TE sort of struggles with is knowing that there's no cure for alcoholism, and that his road to recovery is going to be a sort of lifelong thing. He might not necessarily die from his alcoholism, but as he says, there's no pill he can take that just makes it go away either. So depending on the day, he sometimes sort of struggles with the idea of how long this illness is going to last. So it's going to last him a lifetime. So on a positive note, my patient is currently self-managing fairly well. He hasn't had a drink since he checked himself into rehab approximately 3 months ago. And he recently inherited quite a bit of money from his aunt who passed away. So fortunately for him, he's not stressed out about finding a job or affording his bills. I think that the downside of this is that he's often just lonely and bored at his new house. Larson, the author of our text, explains that effective self-management includes more than just adherence to treatment regimens. It encompasses psychological and social well-being of patients living with chronic conditions. Areas of self-management where I see that my patient really has some room to improve are problem solving and goal setting. Throughout our meetings, he always tells me that he's motivated, but I kind of like to see him behaving a little bit more proactively and putting his words into actions. Barriers to effective self-management include time constraints, inadequate resources, limited coping skills, poor client-provider relationship, and low self-efficacy. Through the creation of patient-centered strategies, case managers like me in this case, can help their patients to realize their strengths and overcome their barriers. So let's take a look at my patient-centered evidence-based plan for TE. Of course, this plan is based on those initial goals that TE set during our first meeting, and the ultimate goal for TE is to remain sober. He knows that in order to do this, he'll need to find some local support in his new hometown. Humphreys, Blogger, and Wagner did a study recently that shows how increased attendance at AA meetings correlated with decreased alcohol consumption among attendees. To a certain point, going to more meetings led to better compliance with sobriety. My patient has had success with AA in the past, and he plans to continue. That being said, however, he's had some trouble recently finding a meeting that works well for him here in Vail. He said that the meetings he's tried to go to seemed cliquey and almost exclusive. And unfortunately, this isn't the first time I've heard this. So I worked with my patient to find a list of meetings nearby that weren't necessarily right in the town of Vail, that were a little bit down valley. And we found a couple of open meetings so that I could go to, and ended up deciding on one meeting that we could go to together on a Thursday night at the Eagle County Fairgrounds. And the meeting seemed to go really well. My patient introduced himself, and we listened to a man speak about his days as a commercial pilot, drinking, flying, and ultimately endangering hundreds of innocent lives. Afterwards, my patient said that it was the most meaningful meeting he'd been to since moving up to the mountains from Denver. He said he'd go again the following week, and I suggested he speak with some of the meeting participants when he went to see if they had any other ideas for more inclusive meetings here in the Valley. My patient also had a goal to choose a primary care provider and find a new counselor close to his new home. McHugh, Heron, and Otto did a study that helps to prove the effectiveness of talk therapy for patients in recovery from alcoholism and addiction. And again, this wasn't really a hard sell for my patient since he'd seen a counselor previously, and he believes it to be worthwhile. So at the end of the 6 weeks, my patient had gone to an appointment with a new primary care provider that we'd selected, and he found the physician to be kind and understanding. He said that his physical exam went well and his lab work would be back soon. The new physician provided my patient with some information about local counselors and even suggested a woman who specialized in addiction counseling. My patient has called her already, but she was on vacation until later in the month. My patient's third goal was to participate in healthy activities that would help him to make some friends outside of the AA community. In the past, he'd found that spending time outside of meetings with AA members was ultimately a trigger for him more than it was helpful. So going forward, he's pretty adamant about making friends outside that AA circle. And since he enjoys exercise and the outdoors so much, I helped him look for local group fitness events like the Pink Veil Ski Race or the Tiva Mountain Games, where he could be able to find some other people who care about health and fitness like he does. We spent actually one entire meeting discussing potential relapse situations for my patient, and we started this meeting by brainstorming high-risk situations that he'd encountered in the past, and he listed vacations, bad weather, and social gatherings as big triggers for him. So for each of these scenarios, we came up with a specific plan that he could follow to prevent relapse to his alcohol addiction. For vacations, my client suggested only choosing hotel rooms without in-suite minibars. In the winter, when the weather is snowy and cold, he plans to volunteer as a greeter at the local ski mountain. This will provide him with an opportunity for some healthy social interaction, as well as prevent him from sitting inside, alone all day long thinking about how badly he wants to drink. Lastly, for social events, he plans to bring his own non-alcoholic beverages to parties and other gatherings. And if he's meeting people out at a restaurant, he'll leave his ID in the car so that he's not tempted to order a cocktail. As you guys may know, there are FDA-approved medications to help manage alcoholism, but at this point, my patient is pretty firm in declining medical management. Moving on to the impact alcoholism has had on TE, I honestly think TE has been pretty fortunate with his alcohol addiction in that it has yet to cause any real catastrophic health problems for him. And like I pointed out earlier, the DSM-5 sort of creates these subcategories for alcohol use disorders. mild, moderate, severe. And if I had to rank TE's addiction, I think he'd probably fall somewhere in that moderate sort of subcategory. That being said, he still suffers from the very negative stigma and social isolation that goes along with this disease. And when he used to drink, he says so did all of his friends. And to some extent, drinking helped him feel less inhibited and less shy. And now, when he's sober, he complains he has no idea how to make new friends or how to interact with people. He spends most of his time at home watching TV or at the gym exercising alone. He thinks that without alcohol, he's somehow less interesting, and he's intimidated to find new friends for fear that they might judge him when they find out about his addiction and his recovery. As a young guy without a spouse or children, TE is struggling to build healthy relationships in his new living environment. And in addition, he's destroyed a lot of his existing relationships with friends and family in favor for his relationship with alcohol. Like I said, the death of his dad when he was 19 was a particularly painful topic for my patient, and apparently that's when his drinking really started to become out of control. He ended up moving out of their family house, and his mom raised his little brother all by herself. This illustration shows some of the damaging effects alcoholism can have on the body. Fortunately, my patient is young and otherwise healthy, but this does show some of the complicated sort of sequelae that alcohol can lead to down the road. Okay, I think we've done a fairly good job of outlining the challenges facing my patient and damaging his quality of life. And I think that many of these challenges have been addressed through his volunteer work, his increased attendance at AA meetings, his selection of a primary care provider, and his participation in local fitness events. My patient is ultimately pleased with his progress over the past few weeks, and he looks forward to continuing his recovery. But one area that still sort of saddens him is his lack of family support. And I don't know how familiar everyone is with the 12 steps, but part of the 12 steps of Alcoholics Anonymous involves making amends to those that you have wronged. And my patient told me he has tried to apologize to his mom and his brother, but both of them say they've just heard it so many times before they don't seem to care anymore. I asked my patient to talk to his sponsor about this because I'm not a recovering alcoholic myself, nor am I an addiction treatment specialist or expert, so I don't have a whole lot of experience with AA and the 12 steps, but I did encourage my patient to be honest and patient and told him that it takes a lot of time sometimes to rebuild lost trust. Perhaps my patient's mother or younger brother would benefit from attending an Al-Anon family group meeting, and I did try to get in touch with his mom about this, but they weren't willing to meet with me or talk with me at this time. I think that TE's family relationships will primarily improve with his ongoing sobriety. He's never stayed sober even this long before, and he'll need the support of his loved ones going forward so that he can have a lasting recovery. Hopefully one day soon he can start having a dialogue with his mom and his younger brother again. I know he wants that more than anything. This next slide represents the care team members that will be necessary for TE's continued success. And I sort of liked this dorky little diagram because it shows how they all need to be interconnected and communicate in order for TE to have success in the future. I'm assuming that the physician, my patient's new physician, and his potential new counselor communicate on a fairly regular basis since the physician recommended the counselor to my patient, and I'm optimistic that he'll be able to set an appointment with that counselor as soon as she gets back into town. Ideally, my patient would like to find a counselor who's available to meet with him once a week or more if necessary. And it can be hard, as everybody knows, to find a good mental health care, especially in Colorado. In addition, I think that there's room for a permanent case manager in my patient's care. Because he doesn't currently have very consistent interaction with family or friends, he could really benefit from someone checking in with him on a regular basis and someone sort of ensuring good communication between his care providers. Lastly, my patient has decided to continue his relationship with his AA sponsor who lives in Denver, and this sponsor, is familiar to him and he feels comfortable with him. So I support my patient's decision, but eventually I think he may want to consider finding a sponsor who lives closer to him. In terms of these sort of health team members' role in the grand scheme of things, primary care providers really are responsible for screening patients for alcohol use disorders as well as other mental health problems. And addiction counselors play an important role in addicts' recoveries. But there's a huge lack of mental health care, as everyone knows, in this state and in our country. And so that is an area where my patient and other patients like him have really struggled to get the support that they need. Lastly, I've left a list of community resources that could help my patient with his ongoing recovery. The Alcoholics Anonymous website includes a list of local chapters and meeting times and locations. The Mind Springs Health website has a 24/7 crisis line for patients that they can call in and receive emergency counseling. And I thought that the Vail Valley Medical Center was important to include because that really is the main healthcare provider here in the Valley. So I put their website on this slide as well. And a list of upcoming local fitness events and information about how to register for those is available at the Vail website. And then lastly, recovery.org offers several options for online support for people dealing with alcohol addiction and other substance use disorders. I hope you all enjoyed my presentation. Thank you so much for watching. I will post my discussion question and the corresponding resources soon as a separate post. Thanks again and have a great rest of your day.